Home Care Association's Joanne Cunningham.
Good afternoon.
Good afternoon.
I'm Joanne Cunningham. I'm the president of the Home Care Association of New York State. We represent around 400 not-for-profit and public and proprietary home care agencies from the tip of Long Island to Buffalo to the North Country. Our members are certified home health agencies, long-term home health care programs, licensed home care agencies, and manage long-term care plans and hospices. First, I want to say thank you very much for having me and listening to the Home Care Association's concerns and thoughts about the executive budget proposal, and also some of our ideas for how to preserve, protect, sustain, and really bolster the home care community across the state. I also want to say thank you to so many of you who raised questions and concerns already about some of the issues that we in the home care sector care deeply about. I have prepared written testimony for you. I'm not going to read it. And I've also given you two reports. One is our 2016 financial condition report. This is a report that the Home Care Association provides every year. We use cost report data as well as survey data to take a look at really the state of the home care industry across the state. What I'm going to do today is talk a little bit about some of the highlights in our financial condition report, and then talk about some of the concerns we have in the budget, and then share some ideas. First, if you read the report, and I'm sure that you and your staff will take a look at it, nearly half of the agencies, home care agencies, providers in the state are looking at reducing staff or doing other kinds of cuts in order to continue their operations. About 70% of certified home health agencies and long-term home health care programs have negative operating margins. That's almost 3/4, and this is a similar trend that we've seen year after year. About half of home care agencies have had to borrow money using lines of credit in order to maintain operations and keep their doors open. And we've seen that trend accelerating over the past few years. On the managed long-term care side, and you've heard some of this in prior testimony, about 63% of MLTCs, and those are managed long-term care plans, so those are the plans providing long-term care for the Medicaid population. 63% of MLTCs had negative premium incomes in 2014, and this is also a trend that is worsening from last year to this year. A couple other data points. On average, less than half of Medicaid claims are paid to home care providers within the dictates of the state's prompt pay law. So agencies' Medicaid revenue is in effect in their accounts receivable for an average about 72 days. And one of the reasons we're seeing that is also something that you heard in prior testimony, the fact that the MLTC rates haven't been kept up to date, and they're struggling on the rate side, so in effect they're not passing the money down to providers. The rest of the data points in the report are all showing worsening financial condition trends, and one of the things we really worry about is what that means for providers as they try to participate in some of the new models that we're seeing the state obviously propose, and the federal government as well. So given those data points that spell a real fragile nature for the home care community in our state, as well as MLTCs, it's daunting to think that these providers are expected to step up and continue to participate in a system that increasingly is relying on them. And we all hear over and over really the description of how we need a robust home and community-based provider network in order to achieve all of the state's policy goals. We heard that in prior testimony from the community health centers. Support and infrastructure investment for home care and MLTCs is urgently needed in this budget in order to secure and sustained delivery system reform. Yet how is the executive's budget proposal responding to this? Of the executive's priority or signature budget proposals, nearly all of them target non-health care for investment. So it's rather ironic that what we're looking at is needed investment in other sectors, yet none of it is focused on the home care side. You've talked a lot about and heard a lot of testimony about the effect of the minimum wage increase. This is deeply concerning for the home care field. We have estimated that it's going to be about a $1.7 billion hit on the home care community, and that's direct costs, indirect costs, benefits, and that ripple effect. We've devised this estimate using data from cost reports as well as other data sources, and we're working together with Haney's and the other provider organizations, Leading Age, the nursing homes, to present a unified front. But if you think about it, the home care number at $1.7 billion is much larger than the hospital and nursing home number together, which is $1.1 billion. Last year, the adopted budget included over $2 billion in new investment funding, largely for the state's hospitals and institutional sector. This support was on top of the $7 billion plus provided to the hospital sector through DSRIP. And the Leading Age testimony that had the pie chart, that is a very telling visual that really shows you the lack of investment that is focused on anything other than really the hospital sector. The home care sector is in desperate need for that investment. We urge the legislature to ensure that healthcare investments in this year's budget include home and community providers, and that any new investments under existing programs be amended to fully apply to the home care sector. A final document that we've given you is a document that looks like this, that articulates two asks that the home care sector has. The first ask is to fix the state's reimbursement laws and levels to cover and reimburse needed services. And we've outlined exactly where that investment needs to occur, but it needs to be placed in adequate rates on the episodic side of the home care provider rate system, as well as in the MLTC rates. We need to ensure that the premiums and the rate calculations include workforce costs. We've already talked a lot about the need for workforce investment. We have the impact of a new mandate that's coming along. Technology, HIT, you've heard from other presenters today about the lack of HIT for any of the non-institutional provider sector. We need to make sure that workforce costs are incorporated in the payment methodology, and we need to make sure that, and this really links with prior testimony also, that the long antiquated state insurance law that covers home care is modernized. We have a state insurance law that outlines the home care coverage that hasn't been changed since the 70s. We need to modernize that benefit. Our second fix really focuses on how do you support and really support the home care infrastructure and operations. And we can do that through fast-tracking regulatory changes. We have been trying to work with the health department for a number of years to think about how we change a regulatory structure that is linked to a fee-for-service system that doesn't exist anymore. We need to be quicker, more nimble at making regulatory changes in a managed care, in a DSRIP, in a value-based environment. And that will help home care providers compete, that will allow them to participate more fully in integrated systems. We also have to harness home care in public health areas. Home care can be critical in sepsis, falls prevention, all kinds of innovations that are really focused on the public health side. We need to harness home care to do more in those areas. And we'll see savings in state dollars undoubtedly if we do that. We also, and I mentioned this briefly, need a proactive HIT policy, a health information policy for home care. We don't have that now. We need to put some infrastructure dollars in and have a state policy so that our home care providers are connected to these integrated models. We have to fund the hospital home care physician program that Senator Hannan was a champion of last year. We need to improve home care quality through innovations, and we need to authorize any kind of innovative new demonstration payment methodologies. In closing, I just want to say again, thank you for your support of home care in the past. We need to do more if we expect this system to be part of and be a critical part of a home care or of an integrated healthcare system. We need to invest in this system so that we can maximize its potential. And the state is relying on us, so we need the help and support. Thank you very much for your time, and I'd be happy to take any questions.
Thank you very much. Any questions, Senator?
No questions, so thank you so much.
Thank you.
Thank you.
Oh, I'm sorry. I'm sorry, Senator Hannan does have a question.
I just would like to follow up. I just want to follow up on each of those points later on in the meeting. I think they're enormously significant. Some of them you've raised before, so like the insurance law and all that.
We'd be happy to, and we have budget language all ready to go, and we'd be happy to sit with you. Thank you very much. Thanks.
New York Health Plan Association, Paul Mezialak.
Thank you.
The next one will be James Little, Council, Management Long Term. Good afternoon.
Good afternoon, Assemblyman. I'd like to thank senators and assemblymen for the opportunity to appear. Hours late, I'll keep it short. As it regards health plans, there's some good news in the budget and some bad news. On the good news front, there's no new taxes. Move it closer. What was that?
Just close.
Work. Okay. Good news. No new taxes, no tax increases. There's no exchange tax, unlike last year. The governor had proposed an exchange tax, which you were able to defeat. It doesn't exist in this budget. There's no guarantee fund or insolvency tax. And I want to make clear that the Health Plan Association strongly opposes a guarantee fund. I would take exception to statements from the representative of the Greater New York Hospital Association, who talked about the crocodile tears of the health plans in opposing a guarantee fund. I'd say that's a bunch of bunk. I would hope he would get his facts straight when he'd be making public statements. He indicated that you should all believe that in New York, that for-profit plans make up the vast majority of plans in the state. It's wrong. The vast majority of health plans in the state are nonprofit, whether they're plans like Affinity, Metro Plus, Health First, Emblem, CDPHP, Independent Health, Health Now. The vast majority are nonprofit. They would all have to pay this tax. He also made the statement that everybody's got a guarantee fund, so why should anybody object to it? I would say the reason we object is because no one else in this country has HICRA taxes to the tune of $5 billion. That's a tax on health insurance, makes it less affordable. It's about 5% of your premium are existing taxes today. A chunk of that $5 billion flows to those Greater New York hospitals, bad debt and charity monies, GME monies. And so if people want to look for funds, we'd say look for existing state funds. A lot of talk today about programs like VAPAP, VAP, QUVAP, healthcare facility restructuring funds. All of those are all state dollars to take care of distressed hospitals. We say you can find in the budget existing state funds to take care of the health republic situation. One other bit of good news in the budget is pharmacy transparency. I think it's a good first step. Requires drug companies to file information with the state about how much they spend on research and development versus things like admin, marketing, and profit. We think it's good, but it only applies to the Medicaid program. And we would ask that it also be disclosed to consumers and businesses in the state, as pharmacy spending is the biggest cost driver in healthcare premiums and directly affects affordability. Certainly the media attention on something like touring pharmaceuticals that had the 5,000% increase in price for an old existing drug by a hedge fund, I think brought a lot of attention to the question of what components go into pharmaceutical pricing. But I'd also point out companies like Pfizer have increased their drug prices on their, I think, 100 top priced drugs by up to 20% for the coming year. So our view would be what's good for the goose is good for the gander, and if it's going to be that kind of disclosure for the Medicaid program, also apply it to consumers and businesses in the state in the commercial market. On the bad news front, in spite of the Health Republic closing, we're disappointed that the governor did not put in any rate reform proposals. Prior approval, the current law of the state in setting commercial insurance rates is a failed state policy. We say you should repeal it, replace it with an objective standard, like the medical loss ratio. We also think that DFS should be required to have actuarial certification of rates. Health plans submit their rates, have to be actuarially certified. We should get back a rate decision from DFS that likewise is actuarially validated and certified. Political price suppression of rates threatens the state health exchange. Health Republic closed. Other health plans have suffered losses in the last 2 to 3 years. All have had their rate applications cut by DFS on a subjective basis. Sustainability of health plans that give consumers access and choice is dependent on rate reform. In terms of the Health Republic scenario, providers lost money, health plans have lost money. There were a number of health plans that were supposed to receive money from Health Republic under a risk adjustment methodology. They're not going to see any of that money. So that is not reflected in prior year's rates. It's going to have to be applied for in future rates. That likewise goes to premium affordability. So we say, please look to existing state resources, and we would suggest looking at state settlements. The governor's fiscal plan identifies and makes the statement that settlements money should be spent as one-shots. They're one-time monies that should be used to fix one-time problems. So we've looked and we've seen that even in the Assembly's Yellow Book, that of the bank settlements, there's still, I think, $2 million of bank settlement monies that have been unallocated. So we think that would be one source that you could look at. Secondly, recently there was an announcement of a tobacco settlement of $550 million, of which the state is supposed to get about half of that. So that doesn't exist on any of these allotment lists. We would say that's $275 million that could be available to help pay providers and plans who have suffered losses as a result of the Health Republic closure. I'd like to turn my attention to the early intervention proposals. Earlier intervention is really the proposals that are in the budget, really are just an old chestnut seeking to shift state-county costs onto insurance premiums so that consumers and business now have to pay for it as opposed to the state or the counties. Historically, EI really is not a medical issue that would be covered by health insurance. It really is a developmental program that was structured within the education department, the education statutes of the state. And what we've been dealing for a number of years with is trying to fit a square peg into a round hole. The managed care rules which exist today are looked to be undercut by these budget proposals. They seek to do a cost shift by eliminating traditional managed care tools on network credentialing, network development, use of medical necessity, prior authorization of services, sites of services, all rules that apply to all providers except, as would be proposed now, EI providers. They would be the exception to the rule. All other providers have to follow these rules except for EI. Now, I know there was some testimony given prior to my appearing that talked about prompt pay and number of violations and delays in payment. I think if you go back to DFS, you'll find that there are no EI prompt pay violations. There are no claims that have not been adequately addressed within the law for EI claims by insurance companies. We get certain rules in terms of 45 days to process a written claim, a paper claim, 30 days for electronic, and providers have to submit clean claims. Now, EI providers are new to the system, so they're new to actually billing on insurance forms following state procedures. So we're seeing a lot of garbage in, garbage out. That explains a good part of the payment delays that providers are seeing. It's not because plans aren't paying, because they're not getting a clean claim for them to process and to pay. Another point that I'd want to raise in that regard is that a lot of these claims are for self-insured plans, and those are not regulated by the state. Plans like the Empire Plan, a lot of school districts, a lot of hospitals, self-insured, they are not subject to these rules. They don't cover EI services at all, but they get lumped into this overall number. Final point, so I know I'm out of time here, is that the Medicaid managed care cuts lack a balance and are really used to just balance the global cap. But they disproportionately fall in Medicaid managed care plans. There are no other sectors that take the level of hits that Medicaid managed care plans do in this budget. We would ask for some kind of a balance in terms of your approach to it. You've heard a lot of testimony from managed long-term care plan rates being inadequate. That same application exists for some of the managed care plans as well in the general field who are suffering losses. So you have a profit tax that's been proposed by the governor. That money is just taken and used in the global cap as opposed to being maybe reinvested or used for some of those plans that are suffering losses. So basically we've got a budget by the executive that has some good components. We look to you, the legislature, to improve on that budget and solve some of the issues. Thank you very much. Any questions?
Thank you. Questions?
Thank you very much.
Thank you, Paul.
Thank you. Next, James Little, New York Coalition of Managed Long-Term Care and PACE Plans.
Thank you very much. My name is Jim.
Excuse me.
Oh, I'm sorry.
Did you give us paper? We didn't get any paper.
Yes, we have testimony for both the Coalition of Managed Long-Term Care Plans and the Coalition of Public Health Plans. I apologize for that. I will make sure it's, we understood it was delivered earlier today. And in light of that, I'll be even briefer in my testimony. My name is Jim Lytle. I represent two coalitions of managed care plans who are devoted to the Medicaid managed care program. Both, as Mr. Maslach referenced, we represent the not-for-profit component of his association in part. All the plans in our two coalitions are not-for-profit, provider-related, provider-sponsored plans. In the New York State Coalition of Public Health Plans, there are 8 plans, 3 million enrollees. They include plans such as Fidelis, Health First, Metro Plus. They represent 2/3 of the total enrollment in the state in these not-for-profit provider-sponsored plans. On the managed long-term care side, we represent 21 plans, over 111,000 enrollees, again, more than 2/3 of the total enrollment. Just by way of background, managed care plans in our coalition and in the one in the Health Plan Association have been the centerpiece of the Medicaid strategy in New York for over 30 years, across 5 administrations, to a point where virtually every New Yorker who's a Medicaid recipient is enrolled in a managed care plan. In context, we're talking about a $20 billion expenditure on mainstream managed care plans and about $5 billion on the managed long-term care side. I should emphasize that these dollars reside in the plans only momentarily and are quickly paid in claims to providers, paid to help provide support to members who are trying to navigate a complicated healthcare system, and paid to help invest in the care management and managed care that is the whole purpose of these programs. I would just highlight a few issues in the budget for your consideration. I would echo some of what Mr. Masalak said. Frustratingly, from our perspective, many of the largest concerns we have in the budget are on the administrative side, steps that the governor and the administration are proposing to take without your endorsement or support, including the profit cap that Mr. Masalak referenced. It's particularly frustrating from the standpoint of a not-for-profit plan whose only surplus is not coming from shareholder investments, but from whatever money it happens to make on premiums paid, to be used for investments in new programs, in new plans, in information technology to assist in the delivery of these services. A proposal on the administrative side will limit the amount of surplus that plans are able to retain. We also would support a number of the proposals the governor advanced to control the ever-escalating cost of pharmacy benefits, particular emphasis on tailoring the prescriber prevails policy to those drugs that are the most sensitive and vulnerable ones in the behavioral health arena, but allowing plans to manage the prescription drug benefit in an appropriate way that is based on the medical experience and based on outcomes and results. The governor has proposed to carve out the transportation benefit from managed long-term care plans as he did last year. Particularly our upstate plans who regard the transportation benefit they provide to their enrollees in managed long-term care as an integral part of what they do, not only to get the enrollee from place to place, including to doctor's offices or to other programs that they need to attend, but to help look in on the individual and to provide other support in addition to the transportation benefit itself. The governor has also proposed statutorily to change the eligibility standard for managed long-term care back to what it used to be, that only people who are nursing home eligible would be entitled to enroll in managed long-term care. We have no particular opposition to that. That used to be the standard. The vast majority of enrollees within managed long-term care plans across the state meet that standard. The only trick is, which is my next point, it's important that rates to the managed long-term care plans are adequate and are determined on a timely basis, and we have struggled with that for many years with the department. You've heard this, and I'm happy to say there was a time where the provider associations, I think at times, testified about their concerns about managed long-term care, their worries about the program, in some cases their opposition to the program. Now I'm delighted to hear that the provider associations are echoing our concerns about the adequacy of the rates being paid to the managed long-term care plans, and we appreciate that. The last point I'd make actually gets back to the mainstream program. Many of our plans who are providing Medicaid managed care on the mainstream program are seeing a significant amount of their enrollment occur through the state's exchange, the New York State of Health. From the very get-go, we have asked that the New York State of Health make it possible for someone who is enrolling in the Medicaid program through the New York State of Health to designate who their primary care provider is. The challenges faced by plans who don't have that information after the person is enrolled in the plan to follow up with the enrollee to find out who the PCP should be has been extremely difficult and has resulted in a significant barrier to the successful transition of of individuals into that program. It's been on the list of things, of system improvements for what has otherwise been a successful launch of the New York State of Health, for which the folks running that program deserve a great deal of credit. But it's important that we make it easier for Medicaid enrollees to access coverage through the New York State of Health and be able to designate right at that time who they would like to select as their primary care provider. With that, I'll answer any questions, and I'll make sure that the testimony finds its way to the right spot.
Thank you. Any questions?
Thank you very much.
Sure.
Thank you very much. Julie Hart, Direct Government Relations, American Cancer Society.